Hello everyone, I am Dr. Prashant, and in this presentation we will talk about the antiphospholipid syndrome. Antiphospholipid syndrome is an autoantibody mediated acquired thrombophilia characterized by recurrent arterial or venous thrombosis and or pregnancy morbidity and occurs primarily in females. Antiphospholipid syndrome may either be primary, wherein it occurs as a single disease entity, or secondary, most commonly occurring in association with systemic lupus erythematosus. A subset of antiphospholipid syndrome, which presents with life-threatening thromboembolic disease involving 3 or more organ systems, is called catastrophic antiphospholipid syndrome. The immunopathogenesis of antiphospholipid syndrome begins with a schematic diagram of a cytoplasmic membrane. These represent the phospholipids. In antiphospholipid syndrome, the antibody may be against the phospholipid themselves, or they may be against these structures, beta-2-glycoprotein and prothrombin, which bind to the phospholipids. Antibodies may be present against them as well. The clinical features and diagnosis of antiphospholipid syndrome is detailed in the Sapporo classification criteria, also known as the Sydney criteria. We will take a look at some of them. Venous manifestations include deep vein thrombosis, livedo reticularis, pulmonary embolism, and superficial thrombophlebitis. Arterial manifestations include stroke, transient ischemic attacks, myocardial ischemia, leg ulcers and digital gangrene, as well as arterial thrombosis in the extremities, renal artery thrombosis, ischemia of visceral organs, and multi-infarct dementia. Neurological manifestations include migraine, epilepsy, chorea, and cerebellar ataxia. The musculoskeletal manifestations of antiphospholipid syndrome may include arthralgia and arthritis. The obstetric manifestations of antiphospholipid syndrome may include preeclampsia and eclampsia. Fetal manifestations may include early fetal loss, which is defined as less than 10 weeks, late fetal loss, more than 10 weeks, as well as premature births among live births. Hematological manifestations would include autoimmune hemolytic anemia and thrombocytopenia. Diagnosis of antiphospholipid syndrome begins with a history and physical examination, as well as testing for the antiphospholipid antibody. These include anticardiolipin antibodies, which is tested using IgG and IgM by ELISA, the anti-beta-2-glycoprotein antibodies, which are tested using IgG and IgM by ELISA again, and lupus anticoagulant. Lupus anticoagulant is a 3-step process: demonstration of phospholipid-dependent screening tests for hemostasis, and these include dilute Russell Viper venom time and activated partial thromboplastin time optimized for this purpose. The second step is mixing of patient plasma with normal plasma, fails to correct the defect, and finally, addition of excess phospholipid corrects the prolonged coagulation test. These tests need to be positive 12 weeks apart to establish a diagnosis of antiphospholipid syndrome. The management of antiphospholipid syndrome involves putting the patient on warfarin for life, aiming to achieve an INR of 2.5 to 3.5. Aspirin may also be given. Pregnancy morbidity is managed with low molecular weight heparin and aspirin, and catastrophic antiphospholipid syndrome is managed with intravenous immunoglobulin 400 milligrams per kg once a day for 5 days along with heparin. If heparin-induced thrombocytopenia or HIT develops, fondaparinux or rivaroxaban may be considered. That's it for our presentation on antiphospholipid syndrome. Thanks for watching, and we will see you in the next video.